Okay, thank you everyone. Thanks so much for joining us today to this month's Lunch and Learn research seminar on the prenatal substance exposure, supporting infants and families to improve outcomes. I'm Jessica Stewart. I'm the Executive Director of Family and Community Services, Insights Analysis and Research, also known as FACSIAR in the New South Wales Department of Communities and Justice. Now, before we begin, I would like to acknowledge that wherever we're joining today's webinar from across New South Wales and beyond, we're all living and working on Aboriginal land that was never ceded. I'm coming to you today from the lands of the Bidjigal and Gadigal people, who are the owners and First Nations people of the area where I have the privilege of coming to you today from, and I'd like to pay my respects to all First Nations elders past and present and extend that respect to our Aboriginal colleagues who may be joining us today. I'd also like to warmly welcome all of you, our webinar participants. For this session, we've had over 1,300 people registered, which is really fantastic. We really hope you get a lot out of this session. And I'd really like to welcome our presenters as well. So the webinar today will focus on joining the dots, so linking neonatal abstinence syndrome to the future study. Professor Ju-Lee Oei is the study lead, and we are privileged and delighted to have her here today to share insights about her clinical work and present her research findings. Ju-Lee will be discussing neonatal abstinence syndrome and prenatal substance exposure, its presentation in hospital, clinical protocols, working with mothers and carers, and outcomes for children. We also have Professor Stacy Blythe, who will draw on frontline research and lived experience and also highlight gaps in carer preparation, the emotional toll on nursing staff, and the importance of attachment-focused, trauma-informed care. Very warm welcome to you both. The research methods and findings presented here today do come from a health science, statistical and epidemiological perspective rather than necessarily a child protection perspective. And we're aware that some of the messaging may differ or not align from our DCJ's current policies and practices, but it is really important and invaluable research. And we have a panel of experts from DCJ who will discuss the practice implications of these findings following the presentation. This will really help situate the findings within our legislative and practice frameworks. As always, our session will be recorded and posted on our FACSIAR webpage. So if you've registered for today and unable to join us today, you'll receive the link to the recording within about a week. So we do have a jam-packed session, so I'm going to try and move quickly through introducing each of our presenters. Professor Ju-Lee Oei is a neonatologist. Currently, she's the chair of neonatology at Mater Research at the University of Queensland, senior neonatologist at the Royal Hospital for Women, and conjoint professor at UNSW. She has led an outpatient service for families impacted by prenatal drug exposure for 2 decades, is the lead author for the New South Wales Prenatal Substance Use Guidance 2024, and the health lead for the United Nations Office on Drugs and Crime Technical Report for long-term care of infants with prenatal drug exposure. We are incredibly fortunate to be speaking with you today. Professor Stacy Blythe is Head of Discipline in Nursing in the School of Nursing and Midwifery at the University of Technology, Sydney. Professor Blythe's research and leadership focus on out-of-home care, foster care wellbeing, and the care of infants with prenatal substance exposure. Drawing on over 2 decades as an authorised foster carer, she brings a strong practice-informed perspective to nursing education, policy and research aimed at improving outcomes for vulnerable infants and families. A very warm welcome to you too, Stacey. We also have Thomas Barron, who's a DCJ Manager of Client Services and leads the implementation of the Pregnancy Family Conferencing Program in Southern New South Wales District. This is a joint program between DCJ and New South Wales Health and focuses on supporting pregnant mothers who are experiencing a range of challenges, including substance abuse in pregnancy, to keep their unborn child safe upon their birth. Welcome, Thomas. And we also have Harula Bakianakis, is a caseworker with DCJ working within the prenatal team. In her role, Harula supports expectant parents and unborn babies by providing early holistic intervention aimed at strengthening safety, wellbeing and long-term outcomes. Harula works closely with health services, community partners and families to identify risks early, build protective factors, and ensure collaborative planning before birth. Harula is passionate about trauma-informed practice, culturally responsive engagement, and supporting families to access the right services at the right time. This is a fantastic lineup. Welcome to you all. Thank you for agreeing to be part of this important webinar. And can I please hand over to you to please go ahead, Ju-Lee.
Okay, let me unmute myself and take control of the slides. Can you hear me okay?
Yes, great. Thank you.
Thank you so much. It's such a pleasure and a privilege to be here. Thank you, Jessica and Sajeev. I see many friends on the attendee list. Hello to my friends from Murrumbidgee, Caitlin Sue. All right, so what I'm going to talk about in this next 20 minutes is how our research has helped identify problems that our families have faced that have remained hidden for many years, just because we weren't aware of it, we weren't looking, or we couldn't look. So these are just snippets. I could talk for about 3 days on this issue, but I'll quickly highlight the concerns that we have. So you know that in newborn exposure to prenatal drugs, the baby goes through what mom will go through. With chronic exposure to drugs during pregnancy, the baby, like mom, will develop a tolerance. But unlike in an adult, when the baby is born, they can't seek any more drugs. And depending on the type of drugs they're exposed to, it may either cause a withdrawal or an intoxication. Hang on, let me work out these controls. So we are most familiar with babies who are withdrawing from opioids because that's what was classically described way back in the 20th century as congenital morphinism. This was a devastating problem because these otherwise normal babies would appear quite unwell in a couple of days. They fed poorly, they vomited, they had diarrhea, they went through profound weight loss, and if they were not treated, the worst would develop complications like seizures, and almost all of them would die. So fast forward to this day and age, pregnant people now use many types of drugs that can cause dependency and addiction. Some are legal, others are not quite so legal. They may cause withdrawal, but they can present in ways that escape our attention. To identify babies who are exposed to substances prenatally is a very difficult process, but I want to bring across our experience in that toxicology screens or drug screenings may not provide more information than a good history from the parent, which is taken under faith. These tests on the babies are very difficult and expensive to do, and they may not come back in time to guide clinical judgment. For example, in meconium tests for methamphetamine, there is a very high false positive rate, especially in moms who take labetalol, which is an antihypertensive medications, and surprisingly, if they eat lots of tomatoes. So the classic withdrawal symptoms come from our knowledge of opioids, and in adults and also in babies, they may go through symptoms like this. But bear in mind that not all drugs cause withdrawal, and not all drugs will cause the high Finnegan scores in the baby. In the floor or in the trenches, the babies are managed best with supportive care. And if you're very used to your Finnegan score, beware that the good baby, one with a low Finnegan score of zeros and ones, may also be a concern. Substances like methamphetamine cause catecholamine depletion, and some of these babies do not know how to call for attention. In the wards, the most important first step is to provide non-pharmacological interventions or NPIs. Do with the family what an unexposed family will go through. Keep baby with mom or a carer if possible. And this has been shown unequivocally to reduce length of stay and the need for pharmacological treatment. Provide small, frequent feeds, preferably with breast milk, that has been shown to reduce the intensity of withdrawal in the baby. unless the mom is intoxicated, if the drug history was uncertain, or if there is active methamphetamine use, which has been associated with infant death. Medications are the last resort, only treat with medication if there is known exposure. So if a non-opioid exposed baby, for example, is treated with opioids like morphine, they may cause respiratory depression and possibly death. Some exposures are multifactorial, so some babies may need multiple types of medications, and some exposures may last for a long time in the baby. And in our experience in our clinic, some babies may need treatment for a couple of months because the half-life of the medication, of the drugs in the baby may last longer than an adult. Remember, gradual changes to any pharmacological treatment because you don't want the baby to have a rebound withdrawal. So if we fast forward on to a baby later on in its life, we're very good at treating withdrawal now, and not many babies will die from acute withdrawal. We're very concerned about what happens to these babies in the future. There's a lot of conflicting and confounding circumstances in their lifestyles, like socioeconomic problems and possibly the effects of the drugs on the baby's brain development itself. You can see from this slide that small studies and limited studies have shown concerns starting from infancy to toddlerhood and to school age, especially with increased risk of cognitive issues, externalizing and rule-breaking behavior, and conduct disorders. So does this really happen in a newborn baby who grows up and who has managed to survive withdrawal? In Australia, the number of babies affected by any type of prenatal exposure is massive. We think that at least 1 in 20 births have some exposure to prenatal drugs that cause addiction and dependency. This is equivalent to more than 15 to 20,000 babies per year, very much more than the babies who are born very preterm. We are very fortunate in Australia to have the capacity to link our data across lifespan. So almost all states and territories are able to connect the dots between a person using identifiers such as names, medical record numbers, addresses, and parents' details. In New South Wales, each person can be linked at least 8 times through databases like that I've shown on the slide, and this can provide a profile of the patient's life across the lifespan. About 10 years ago, we conducted our first data linkage study. We wanted to see what happened to babies who were diagnosed with Neonatal Abstinence Syndrome, which is coded as P96.1 in the left bottom icon there on ICD-10 discharge codes. We wanted to link these children to a possibility of death and to see what happened when they reached school. So the Sherrill Department, Centre for Health Record Linkage at the New South Wales Ministry for Health, conducts these linkages for research and audit purposes. So in this study, we looked at birth data, ICU data, admitted patient data, which is hospitalization to identify our cases of NAS, and death data. So Hannah Ubel, my amazing student here, who is now a community pediatrician, did our first study. She compared more than 1 million babies who were born in New South Wales over 11 years to almost 4,000 infants who were diagnosed with neonatal abstinence syndrome before they left their birth hospital. She tracked them to 12 years of age for the oldest patients. What she found in moms was not surprising, unfortunately. The yellow column represents the mothers of babies who were diagnosed with neonatal abstinence syndrome. You can see here they were younger, more likely to be of indigenous ethnicity, had no antenatal care, and came from the lowest economic quintiles. Their babies were more likely to be low birth weight, preterm, had a difficult entry into life with low APGAR scores, were more likely to be admitted into our nursery, and had a longer duration of stay in the hospital of birth. What we found later on was that even if they were discharged from hospital of birth, they kept coming back into hospital, and they kept coming into hospital until they were teenagers. The reasons for hospitalization were external. By this, I mean that they came into hospital for conditions that were not of their own health. So they didn't have cancer, they didn't have, heart problems or other issues that other children came into hospital for. If you look at the yellow column and blue writing, you can see that children with neonatal abstinence syndrome came into hospital because of external causes like injury, poisoning, accidents, and assaults. And on the bottom, they came into hospital for this devastating conditions at a significantly younger age, at 4 months compared to 11 months for other children. They were also brought into hospital for evaluation of mental and behavioral disorders, including behavioral and emotional problems. And on the bottom, you can see that they were brought in with these conditions at a significantly older age, at 5.5 years, meaning that they probably got picked up when they entered formal schooling and at an age where intervention would be less effective. The other question we asked was, were they at increased risk of death? And we found that while the babies were in hospital, they did not die. But between the ages of 1 month and a year, they were almost 8 times more likely to die, equivalent to a death rate of 3 times that of other children. The risk of death, you can see on the red line there, which is a survival curve, was continuously lower compared to other children of New South Wales until they were teenagers. And you can see in this table that they died of causes, again, that were external, like accidents, assault, and sudden infant death syndrome. The final question we asked was whether they did well or poorly at school, because school failure is one of the most important outcomes of a child's trajectory. Children with prenatal drug exposure usually have many competing factors in their lives, including parental psychiatric comorbidities, lower parental education, great family morbidity, nutrition, poverty, and poor parenting references that can impact on their schooling. So those of you with kids would know this NAPLAN score report, which is a standardized Australian school test taken by every Australian child 4 times in their life. A standardized test means that the scores of these children should increase as they become older and gain more skills. Children who do not meet minimum standards for the NAPLAN test at each level need more help to proceed on to the next level of schooling. In our study, we found that almost 50% of children with NAS failed to meet national minimum standards by year 5, which is age 10 to 11, compared to only 1 in 5 of other children. And this is a very sad story because you can see that the scores of the children with NAS start low. They stay low compared to the other children, but by the time they're in year 7 or the first year of high school, their scores are lower than children in grade 5, which are 2 years younger. So can we do anything to protect or mitigate these poor outcomes? Child protection services are integral in children with prenatal drug exposure, but tracking children with a history of prenatal drug exposure and child protection services is very difficult. There are studies showing that any contact with child protection services may lead to excess child deaths, but prenatal drug exposure itself, as I've shown, also leads to excess child deaths. So Kate Lawler, one of my amazing medical students as well, and also a UN intern, did the following studies. And what Kate asked was whether child protection services could reduce the risk of death in children with a history of prenatal drug exposure. And in this study that was updated from Hannah study, we received data from DCJ evaluating the contact with out-of-home care services for children in New South Wales born over 20 years. This is case data set. So we extended the New South Wales data set until 2020, which was 1.8 million births. And we could categorize the children into 6 groups and a control population. As you can see in group 5 and 6, children who are exposed to drugs with and without NAS. The main causes of death, again, were sudden infant death syndrome, but you can see on the table at the bottom, children who were not diagnosed with NAS had a 3 times increased risk of death, but those who were diagnosed with NAS who stay in our hospital, sometimes for weeks and months, had almost a 5 or more than a 5 times increased risk of death. Any child with PDE or prenatal drug exposure had an increased risk of being of any exposure to out-of-home care, up to 30 times more likely by 6 months of age. But any contact with out-of-home care had the potential to reduce risk of death by 75%, specifically in children with prenatal drug exposure. And you must note that although there is an increased risk of death for children with drug exposure, over the 20-year period of study, less than 1% of infants with PDE will die. Out-of-home care contact will reduce the risk of death from external causes in PDE, especially from assault, self-harm, and sudden infant death. In the second analysis, what we did was we showed that any contact with out-of-home care in children with PDE, it decreased risk of death, but was associated with an increased risk of death if there was no previous drug exposure. So the final analysis, I suppose, was our comparison of out-of-home care or school outcomes in children with and without prenatal drug exposure. And in this analysis, what we found was that unfortunately, there was no impact on their school outcomes, which remained poor. So something else must be happening to cause these children not to do well at school. So the take-home messages from this study is that we now know that children with prenatal exposure have an increased risk of poor outcomes, regardless of whether they are diagnosed with neonatal abstinence syndrome or not. They may not receive equitable care, which may compound the harm caused by intrauterine drug exposure. We need to be cognizant that just like any other child with a medical problem like a heart condition or with cancer or whatever, children with prenatal drug exposure need support beyond the neonatal period. We acknowledge that although death is a limitation in this study, it is important to assess and plan individual supports that suit each family. So with this, I will pass over to my friend Stacy. I thank you for your attention. Thank you.
Thanks, Ju-Lee. I always love hearing you speak, and that's amazing to get through 50 slides in 20 minutes. So well done. Hi, everyone. My name is Stacy Blythe, and as Jess said in the introduction, I'm a registered nurse. I'm head of nursing at UTS, and I've also been in authorized foster care for 20 years. Actually, over 20 years, but I don't want to say that because my hair is already gray enough. What I'm sharing with you today is a culmination of some of my research, as well as my firsthand experience of being in care to a beautiful Indigenous sibling group of young people now for that 22 years who have experienced firsthand prenatal substance exposure. What I want to do is shift us into the real world context and not necessarily in the hospital of caring for infants with prenatal substance exposure or drug exposure, particularly once they leave the hospital. While Ju-Lee has talked more about the clinical and research perspectives, I want to center on the lived experiences of nurses and parents and carers who support these infants day to day, often in homes and community settings. These infants can present with complex mix of challenges. They may be highly irritable, have feeding and sleeping difficulties, and show early signs of developmental vulnerability. But what really shapes the outcomes is not the infant's clinical presentation. It's how prepared and supported the parent and caregiver is. Foster and kinship carers in particular often step into this role with little notice and limited training. And when carers don't feel confident and supported, infant well-being is affected and the caregiver's stress and burnout increase. This highlights a clear need for structured practical training that helps carers feel capable and safe in meeting the needs of these infants. We also acknowledge that the impact on neonatal nurses. Caring for infants experiencing withdrawal or instability is emotionally and physically demanding. Nurses describe the toll of persistent crying, difficult soothing, and moral distress when care feels fragmented. These frontline experiences remind us that ethical, effective care must support both infants and people caring for them. So taking this human-centered view, especially around the transition from hospital to home, we can see where the system falls short and maybe where we can make some possible improvements. The transition from hospital to home is one of the most vulnerable periods for infants with prenatal drug exposure. Yet it's often poorly coordinated and it's under-resourced. And while infants may receive intensive monitoring in neonatal units, that level of structured support can drop off quickly after discharge, even though feeding issues, sleep dysregulation, and sensory sensitivity can persist for weeks or months. Many foster and kinship carers report receiving little to no direct guidance about infant triggers, soothing strategies, medication needs, or what to expect as withdrawal continues. And as a result, carers often begin their role feeling anxious and unprepared. In practice, this leads to wide variation in care. Some carers seek frequent medical help, while others may miss early signs of concern. Community nurses also describe seeing infants with no clear documentation or care plans, which adds pressure to the already stretched services and increases the risk of fragmented care. A more integrated transition pathway could make a real difference. This includes clear discharge protocols, documented care plans, and mandatory communication between hospital teams and the out-of-home care services. Strategies such as early home visits, warm handovers between nurses, and opportunities for carers to observe care routines before discharge can support safer, more consistent care, while also reducing preventable readmissions and carer distress. Foster and kinship carers play a critical role in supporting these infants, and yet the research has consistently shown that many are not adequately prepared. A significant number receive no formal training in relation to basic infant care, such as feeding, sleeping, or bathing, before an infant arrives in their home. Even carers with parenting experiences of their own often find that the previous knowledge doesn't translate well to infants with complex regulatory needs. Guidelines have changed, and caring for infants experiencing withdrawal or dysregulation is very different from typical infant care. Many carers describe teaching themselves online, using informal advice from their peers, and this contributes to anxiety and self-doubt, especially when the infants are hard to soothe or read. And this pressure is heightened by the responsibility that they hold within the out-of-home care system. So targeted specific infant training can make a substantial difference in this space. Nurses are central to caring for infants with prenatal substance exposure, and yet their voices often go unrepresented. In neonatal units, nurses care for infants experiencing withdrawal, managing constant crying, disrupted sleep, feeding difficulties, and heightened sensitivity. And this requires sustained emotional labor and careful individualized care. Nurses often describe feeling torn between following clinical protocols and responding to the infant's need for comfort and human connection. Over time, this can lead to compassion fatigue and burnout. And many nurses also worry about what happens after discharge, knowing that many parents and carers may not feel fully equipped to care for these, to provide routine care in the home. These experiences point to a broader workforce sustainability issue. Supporting nurses may involve trauma-informed models of care, genuine trauma-informed models of care, not rhetoric, opportunities for debriefing and practical supports, making nursing experiences visible. We can design systems that care for both the infants and the professionals who support them. Attachment is foundational to infant development, yet it can be particularly complex for infants with prenatal substance exposure. These infants can be hard to soothe. They struggle with regulation or appear unresponsive, behaviors that can make bonding much more difficult. Mothers may experience distress or self-blame if bonding is disrupted in the hospital. And if infants enter out-of-home care, they must form new attachment relationships with carers who are often meeting them for the very first time. Supporting attachment requires intentional strategies that consider both the infant behavior and the caregiver emotions. Practices such as skin-to-skin contact, consistent routines, transitional objects can support regulation and connection. Coaching carers and parents to understand infant cues and the role of early trauma is also key. Strong attachment acts as a protective factor, supporting long-term development. Embedding attachment-focused practices across the hospital and community care helps buffer the compounded risks these infants face that Ju-Lee outlined for us. So improving care for infants with prenatal substance exposure requires coordinated cross-section action. Key priorities include standardized hospital-to-home transition protocols, warm handovers between services, and clear individualized care plans that follow the infant. Many foster and kinship carers report receiving little to no direct guidance about infant triggers, soothing strategies, medication needs, or what to expect as withdrawal continues. And as a result, carers often begin their role feeling anxious and unprepared. In practice, this leads to wide variation in care. Some carers seeking help, others not. Embedding child and family health nurses within the out-of-home care services can strengthen continuity and provide carers with accessible expertise. Mandating infant-specific training for foster carers and kinship carers before placement is also critical, covering both basic care and the unique needs associated with prenatal substance exposure. Stronger collaborations across health, community, and child protection systems are needed, supported by shared documentation and regular communication. This can reduce fragmentation and improve outcomes. These reforms support carers while creating safer, more consistent pathways for infants. Infants with prenatal substance exposure are among some of the most vulnerable in our systems, and yet carers and professionals supporting them often work without adequate coordination or resources. Today, I've highlighted some gaps in transition planning, training, and attachment support, and cross-sector collaboration, drawing on the lived experiences of both nurses and carers. Strengthening the link between hospital and home is central to improving long-term outcomes. When we invest in carer training, support frontline staff, and build integrated care pathways, we create real opportunities for these infants to thrive. This is a call for continued collaboration across healthcare, social services, and out-of-home care. With a shared commitment, we can reshape the systems that support infants during their earliest and most influential stages of life. As a carer for 22 years, I can tell you that I've seen this can be done well, and I've seen it done really poorly. When we support the parents and the carers, we get better outcomes for the children. Unfortunately, the way that our system is currently set up, health services and out-of-home care child protection services don't communicate as well as they should. In a study we did with carers talking about receiving care of an infant, many of those carers received the infant who had been discharged from hospital that day, but picked up by either a caseworker or a transport worker and then delivered to the carer. So the handover of the infant's needs went from one person to another to another. That can be really problematic, particularly if the information that's been given by a healthcare professional to a social service professional, then to a carer, isn't well translated. We can do these things much better. We also have sustained nurse home visiting programs that look after families who are facing adversity, including families who have substance use issues. But when child protection has to become involved and the infants are removed from those situations, when they are reunited with their families, those services are not reinstated. And there is no real good reason for that other than poor referral pathways. Further, when those infants go to the foster carers, those services don't follow and support the carer to look after the infant because the mechanism of referral is always through the mother. There are some really clear ways that we can improve these systems. It's not rocket science. It's something that we can do quite simply. And I hope it's something that you feel challenged about today. I'll hand back to you, Jess. Thank you.
Thank you so much, Stacey, and thank you so much to Ju-Lee as well. Two really terrific presentations and a lot to consider. Well done getting through so much content so quickly. I'd now like to turn to our Q&A session and bring in our panel members. And please, just a reminder to everyone to please put any questions or comments that you may have in the chat. I can see there's a few there already, but there may be time to cover off some of those shortly. So firstly, can I turn to you, Thomas, just to reflect on the two presentations and the findings there, and what are your reflections from a DCJ practice perspective?
Yeah, thank you. Look, there's two main takeaways as from my perspective, mostly in relation to Ju-Lee's work. The first takeaway is from a practice perspective, I think it's important for DCJ staff to remain informed and up to date on the relevant information relating to the sorts of issues that newborns face, and be purposeful and respectful and curious with mums in our conversation. I do feel we can use information in this presentation to inform our conversations with mums and families. We know that pregnancy is a key time in a person's life where parents are motivated to make change, and we know that as caseworkers we can motivate change by encouraging parents to think about what they want for their kids. In our conversations with parents, we can be sharing some of these statistics and educating parents about the outcomes of the different decisions that they can make. But I do want to just share a note of caution for casework staff within DCJ. Though the research reveals interesting statistics and it's important that DCJ staff remain mindful, I think it's important we remain mindful of the way we work with families, and in particular our Aboriginal families. I would like to reinforce the importance of partnering genuinely with Aboriginal people in the prenatal and the postnatal space, and rather than relying on a compliance-based approach without considering how the historical and ongoing surveillance of Aboriginal people has generated a lack of distrust in the department and in health services. And that continues to shape the experience of Aboriginal people today. We spoke about, or child deaths were discussed. I think it's important that we understand that context, but I also think it's important that caseworkers understand that while statistical likelihoods of certain outcomes may increase in a certain cohort of children, it does not necessarily mean the child that you are working with today will experience that outcome. So it's important to understand what we've discussed, but I just want caseworkers to not be too alarmist about what they may have heard today or what they have heard today. I think it's also important to remember our assessments for babies upon birth need to be focused on the present and the future. Of course, we would prefer parents don't use drugs during pregnancy. As part of our assessments, we should certainly try to understand previous decisions and previous patterns of decision making, because we know that past behaviour can be a good indicator of future behaviour. But our assessments upon birth of a child, need to focus on whether the parent can make the right decisions for their baby to keep them safe now, to provide adequate care for their baby now, and what supports can be put in place to support that. The second takeaway I have is, to me, the research highlights the importance of early reporting to DCJ by anyone working with pregnant mothers. In particular, that would be our health colleagues. So prenatal casework is aimed at reducing the risks that have been discussed today. And as I mentioned earlier, pregnancy is a prime point in a person's life where they're motivated to make some changes. Prenatal casework by DCJ caseworkers can only be done with the parent's consent, and it takes time for the caseworkers to build enough rapport with the parents to bring them to a place where they feel safe to give that consent. Once we start working with the family, DCJ need to put in place plans and supports to help a family to make changes to keep their baby safe upon birth. And those supports and plans can take time to get up and running and take time to generate sustained change. So for DCJ to be able to give the best opportunity to parents to be able to provide safely for their child upon birth and reduce the likelihood of some of the poor outcomes that have been discussed today, we need early prenatal reports. Once we have those prenatal reports, DCJ need to focus on early allocations and begin a long process of encouraging sustained change as early as possible. I do want caseworkers and casework staff to remember that DCJ has a legislative mandate to make active efforts towards preventing children from entering care and to ensure that families are involved in decision-making and providing support to parents to care safely for their children. That work, we know, is more likely to be successful if we start that earlier in the piece than later. I do want to emphasise that children born following prenatal substance abuse during pregnancy can be cared for safely by their parents upon birth, and caseworkers in the prenatal space see examples of that every day. And I will hand over to Harula to give some examples of that.
Hey guys, thanks, Tom. I guess from a prenatal perspective, I guess one of the biggest things the research pointed out was babies really do go through what their mums go through. And that's something that we talk about a lot with our families, not in a scary way, but in a way that helps them understand why their presence matters so much. I guess we talk about when mums can stay close, like room in, breastfeed, if it is safe, just to be with their baby, you really see the difference. And that's something that we often talk to our families about. I guess babies settle faster, they cope better, and withdrawal isn't as intense. So when we're able to do that, and so hearing that backed up by the research just reinforces what we're really trying to do every day. Another part that stood out to me was about the testing, things like meconium screens and NAS scores. In our work, we're really upfront with the families that these things don't measure parenting. Meconium can be wrong. NAS scores don't reflect someone's capacity. They're clinical tools. So we don't make decisions based on numbers, I guess, is the messaging that on the floor is what we try to do every day and give to our families. We look at how a parent shows up, their honesty, their willingness to plan, how they engage with support. That's what actually matters for our safety, for the safety that we kind of look at for mums, for parents, for families. The slides also highlighted all the long-term risks for kids with prenatal exposure, so more hospital visits. I heard about developmental struggles, things that are often tied to bigger issues like poverty and mental health. And for me, that's a reminder that being punitive doesn't help anyone, right? So a lot of these mums have already been carrying so much. These families have gone through so much already, and our job is to take some of that weight off and not add more to it. Obviously, as caseworkers, it's something that we want to remember. So day to day, my work is really about building trust early, breaking down shame, supporting mums, through antenatal care, being creative in how we keep families safely together, including, doing PFCs, prenatal family conferencing, collaborative approaches with stakeholders, and having big meetings with health, and really coming together to see how we can move forward. Because I guess putting baby first doesn't mean separating them. Means most of the time it means strengthening mum, strengthening the parents. So when I reflect on the findings, they give a language to what we're already seeing. For us, they help us explain the why behind our approach, and they support the idea that safe connection, not separation, is what gives the babies the best start. I guess if we can use evidence and compassion and creativity to keep families safely together, then that's the work that's worth doing for me. And I just want to say, I'm really proud to be part of a team that kind of shows families what's possible when support replaces judgment. And I want to be able to take these facts, these evidence, to take it away, inform our parents, but really the takeaway message for me is that early engagement changes outcomes. So yeah.
Thank you so much. So I think too, you might have had a case study that you wanted to share with us. Is that something, Harula, that you wanted to cover off now? And then we do have time for some questions after that.
So I guess I wanted to share an example that kind of brings all of this to life a bit. I guess de-identifying. So Ava was 21 at the time, mum that we were working with and referred to our prenatal team. She had a long history of trauma. Her mental health was up and down, and she was using methamphetamines at times to cope, especially when things escalated with her partner. From the very beginning, we worked with Ava in a way that reflected exactly, I guess, what the research kind of talks about. So she came to prenatal family conference with her supports, health and DCJ, and we were honest with her. We told her that we were worried about what we were worried about. We were just, clear about what we wanted to support her with. Stabilizing her mental health was really important, and reducing her use. It was hard, of course, and, building safety around her, took a little bit to so she could be the best parent to her baby. I guess in the times that we were working with her, there were certain things that she kind of did to, like, downloading an app to track her drug use and triggers. She shared that with us openly. We were able to talk about the facts and that certain evidence tools that are used, but not to used in a way to see what her capacity, around, talking about that we're looking at capacity and what she's able to do in terms to engage with us. There were sip-ups, and she told us straight away, each time she relapsed, she re-engaged with support. It was consistent, it was honest, and that's what kept her and her baby safe. When baby was born, there were that she was healthy and full term. I guess on day 1 and 2, baby had some mild tremors, which can happen for lots of reasons: hunger, overstimulation, changes in temperature, not just withdrawal as well. But I guess the nursing staff did NAS observations and baby's 4 to 3 at the time, to be quite specific. This is where the research really connects to practice. We didn't treat that score like a parenting assessment. We kind of explained that. This is what it means, but this is what we're looking at. So we worked alongside the hospital, supporting Eva with breastfeeding and helping her understand what the observations meant. And by day 3, the NAS scores were back to 0, no signs of withdrawal. And after birth, I guess our focus shifted to attachment and safety for us, with the help of midwives, child family health nurses. We encouraged skin to skin, following baby cues, keeping the environment calm, and using paced feeding. Ava was really gentle. She had kind of come around. She was responsive. She understood what it meant, what the dangers were, what that means for her after, and what she needs to do. And you could actually see her confidence growing. We built a collaborative discharge plan with Ava and the hospital, and her mental health team. Baby went home in her care with regular home visits, a really strong network around her. And now baby's 7 months old, thriving, meeting all her milestones, and deeply bonded. You can really see the shift and the change in mum herself. So Ava's still engaged with mental health support. She's still using her tracking tools. She's still showing insight and consistency. And for me, that's exactly what today's findings are kind of about. When you you take that, you talk about it, and when you reduce the judgment, when you build trust, when you focus on safety and connection, even when there's substance use, even when NAS scoring happens, families can stay safely together, and babies do better because of that. So that's when I was thinking about a scenario that's what came to my head, because this was it was an important takeaway to be able to remember that there are some of this stuff here today that we've learned that I can also take away and educate the families, the mums that I work with, to create safety.
Terrific. Thank you, Harula. So I might come to some of the questions in the chat now, if that's okay. So there's a few comments in there about the lack of specialised training. And do you know of any specific training for midwives or child family health nurses and for DCJ workers to educate, to help educate around these issues? Ju-Lee or Stacy, are you aware of specific training that might be available?
0. Okay,
Right.
so I've replied there. So we've done several submissions to highlight this issue. So
Right.
we did a review, found that there were more than 70 different specialties that are involved in the care of many of our families, and none of us have any training in this area. Many of us fall into it because we probably couldn't run away fast enough, or we were interested ourselves. It's a self-educated journey. And that shouldn't be the case. It should be highlighted with the pediatric college, it should be highlighted in the GP college, and every clinician that has to look after a family. And it has not happened.
Okay. Well, that's something that we need to consider going forward. And there was another question in there around accessing the NDIS. Do you have any advice to support carers, parents, caseworkers?
We're trying to link up NDIS data to our DOTS data set. What we hear from other jurisdictions, like the magistrates from Children's Court, is that inevitably the children that present to them with a history of prenatal drug exposure, plus or minus withdrawal, are almost always globally developmentally delayed. We know from our studies is that global delay is manifested as early as 6 months of age, and it's consistent with abnormalities in the MRI scans that continue until they're in school age. The trouble is many of us do the usual cognitive testing that we conduct on many children with medical illnesses like the preterm kids, and many of the children with prenatal drug exposure seemingly pass these tests in the first years of life. So we label them as being neurologically normal. But then whether it's other circumstances like socioeconomic difficulties, family chaos or whatever, or maybe the indolent impact of these drugs on the developing brain, what we see is a terrible regression or a trajectory that is almost always predictable. These children fail to meet educational milestones, they have conduct and behavioral issues, and they have trouble with growing to meet their needs. So I think we are falsely reassured by the fact that, okay, number one, they survive withdrawal. Number two, they pass their early infant cognitive testing, and that means that they're okay for the rest of their life. Stacy, you've had experience.
Yeah, I mean, that's what we see. That's what we see happen over and over again. And we have some people who would continue to deny that that's what it is, and they blame other factors, which, yes, those other factors are there and they compound things. But I can tell you the first time I saw Ju-Lee present the data that she did on the NAP plan, I felt like I was looking at the scores of the children that I was raising at the time, because that's exactly what I was experiencing firsthand. And we hear it over and over and over and over again from both parents and foster carers of children who grow up with this sort of start in life. So it's very clear. I will say, in terms of training, there is one nurse home visiting program that is in different places in Australia. It's not Australia-wide yet, called the MESH program, which is the Maternal Early Childhood Sustained Home Visiting Program. It has additional training within that program for child and family health nurses, specifically in relation to supporting families where there's substance use issues and being able to highlight those developmental needs for those young children. There's nothing after that because people just deny that there is an issue. And when it comes to foster care training, like I said, my research has shown there isn't any out there. I have developed a workshop that I do deliver when asked for carers to help prepare them. Because if we don't prepare them, they're not going to be looking for those developmental delays the way that they should. And they find out often later, we should have been doing something different earlier. And then they have to deal with that feeling of having let the child and the family down. So the better prepared they are, the better outcomes we're going to get for the children in care.
Absolutely. Thank you. And just sort of related, there's a few comments in the chat around the lack of service supports in rural and remote areas, and that sort of lack of support as children get older and, may not are turning up then at school, but, perhaps what more could we be doing working with other agencies like education, and separately, what can we do about the limited services that might be available in rural and remote areas? Do you have comments on that as well?
I can tell you that I had an experience myself being invited to Roxby Downs a number of years ago to provide training to the whole town. We had educators, we had social workers, we had healthcare providers, a variety of different, we had police, everyone turning up because substance use was rife within that particular mining town, and they were experiencing all kinds of difficulties. And unfortunately, they had one psychologist who visited once a month for one day. and that was their access to services. Otherwise, they had to drive a long way away. There is a real need in the rural and remote areas. And unfortunately, we know that substance use is often higher in some of those areas. So the need is probably even greater there. If I had a magic wand, I'd fix it, but I don't know what we do to get the people there that we need to support these families.
Thank you. And another comment that the Thriving Kids, Foundational Supports Thriving Kids reform may provide an opportunity for improving access to support services. There's also a question, we've probably got time for more. There's a few questions around, I think I was surprised as well, just as how common it is. Ju-Lee, I think you mentioned 1 in 25 mothers may be affected. There's some questions about siblings, but did you just want to comment? I'm really interested too, whether you've seen trends over time as well as increasing or decreasing prevalence, because there's not a lot of data for us as to whether we're seeing more and more complex children just more generally in the child protection out of home care system. But these are the types of things that we're keen to understand whether that risk is increasing in the population.
Okay, I think the issue with what we're seeing is the change in exposures. So when I started training, when I was a little baby, opioids were the main exposures. So you had the women who were on heroin and then on methadone, and their babies behaved in a very expected trajectory. But nowadays, there's increased access to a lot of substances that many of us have never even heard of, right? They buy them on the dark web. There's there are different, different exposures that we need to be cognizant of. That and especially the non-opioid substances like tranq or ketamine, GHB, that could cause very different impacts on the baby and the family. Whether withdrawal itself is increasing, no. So the classic neonatal abstinence syndrome that we associate these impacts on are not there anymore. The rates have plummeted everywhere, but that doesn't mean that the children are not affected. So, they're affected by vapes, by cannabis, by, prescription medications, which are increasing. So I think we need to be flexible in our thinking when we look after our families, and to acknowledge that not all these exposures cause the same immediate outcome, but the long-term trajectory is unfortunately very, very consistent and clear.
Yeah, can I just add to that, Jess?
Sure.
Ju-Lee and I wrote, along with some colleagues, an editorial a couple of years ago talking about the fact that there is no persistent diagnosis for these children. So those who are born and experience the withdrawal syndrome might get the diagnosis of NAS, but then it's gone as soon as the withdrawal is gone. And so there is nothing to flag that these children have something in their history that's affecting their ability to grow and learn and develop in a proper way. Children who are exposed to alcohol might get a diagnosis of fetal alcohol spectrum disorder, but these children don't. And that is a real problem, because it's difficult then to try and explain to schools, to carers, to healthcare practitioners who aren't familiar with it, that it is a legitimate issue because there isn't a diagnosis that goes with it. And that's something that we've been trying to change for a while, haven't we, Ju-Lee?
That sounds incredibly important to solve. So look, there's a number of areas that I think we need to continue to work together on, particularly around getting a diagnosis, but also the support services available, not just immediately after birth, but continuing on throughout childhood. I'd really like to thank you again for joining us today. If I can just ask each of you to, if you have one takeaway message for the audience to take away today, and can I start with Harula, going backwards order?
Okay, yeah, just early engagement changes outcomes. I think if we can get in early, and we can do the work that we can do prenatally before baby's born and get it where we can get it, then that would be amazing, better outcomes for babies, for kids.
Thank you. Thomas?
I would second that. That's my biggest takeaway. The earlier DCJ can get a report about children who need, or pregnant mums who need support, the earlier we can get in. I saw a number of comments in there about DCJ close due to competing priorities. That is unfortunately the reality with many reports, but the earlier we get reports and the more we get reports, we have more opportunities to get in and support parents in a way that can help them keep their baby safe upon birth.
Thanks, Thomas. Stacey?
Yeah, thanks, Jess. I think the thing that we need to realize is that we need to keep the children front of mind, which is why we're all here. And that in order to do that, we need to be supporting the people who are supporting those children. So the carers, the parents, and the clinicians that are working with them every day. This education and training.
Thank you so much. And we'll finish with you, Ju-Lee.
Oh my goodness, have you got 3 hours to spare? I think, look, from the last 30 years experience, what I'm appreciating is our lack of education and the fact that we're learning more and more about this condition that needs to be appreciated as a medical condition. I think we often blame it on the socio-economic and other situational circumstances that, oh, if these families have a better life, then the kids wouldn't be in so much trouble, right? But we keep forgetting that many of these substances are very important to mom's health. And many children are exposed, not because of, circumstances beyond our control, but maybe because mom needed these medications. I think what is most important is that we all need our knowledge to improve. We need to be aware of the continued long-term impact of substance exposure, and also to continue to work and to get research done to improve these children's lives.
Fantastic. Thank you. Well, thank you so much again for today. Thank you all for joining us. And I'd just like to quickly invite everyone to our next Lunch and Learn, which will be held on the 21st of August at midday. And that webinar is titled Embedding Culture in Child-Focused Practice for Multicultural Children in Out-of-Home Care. So we hope to see you there. For now, thank you again so much and have a great rest of your day. Thank you.
Bye.
Bye.